So welcome everybody. A few more people may kind of come in, but we'll go ahead and do our introductions. We want to welcome everyone to the September version of the JVS Journal Club. We're excited to have a Venous focus this month, and our two host institutions are Tri-Health Good Samaritan Hospital and Loyola University. The two articles that we'll be speaking about tonight on our Venous-focused JVS Journal Club are the clinical outcomes of venous self-expanding stent placement for Iliofemoral venous outflow obstruction, and also pelvic venous insufficiency secondary to iliac vein stenosis and ovarian vein reflux, treated with iliac vein stenting alone. Our two institutions, again, Loyola University, Dr. Carlos Becerra and his second-year fellow, Dr. Kayla Zorn, will be speaking on pelvic insufficiency secondary to iliac vein stenosis. And then we're also fortunate to have Dr. Patrick Muck from Good Samaritan Hospital in Cincinnati, Ohio, and Dr. Adam Reichert, and they'll be covering the article on venous self-expanding stent placement. Just a few, we're also very thrilled to have our two guests this evening that will be moderating. So Dr. William Marston is from the George Johnson Jr. Distinguished Professor, Division of Vascular Surgery at the University of North Carolina. And from Oregon Health and Science University, we have Dr. Amine Politano, who will be moderating with us. A few housekeeping notes. One, we do ask that you stay muted. We're a small group, so when the time comes for the moderator to discuss some of the papers, we may ask you to unmute and ask your question live. We will be monitoring the chat, so please put your questions in the chat for the moderators. The event is being recorded. If your trainees are not able to be here tonight, it can be watched. The links are on the JVS website. We will have our next JVS Journal Club in October. It's October 13th at 7 p.m. Central Time. It's being hosted by the University of Florida and also Lenox Hill Hospital. So I am going to stop this presentation and I'm going to bring up the first presentation, which is with Dr. Carlos Becerra. And do you want to go ahead and get us started, Carlos?
Yeah, thank you, Mr. Sorry, I'm having some issues with connection. I'm not sure if you guys can hear me. Looks like I'm on right now.
We can.
Okay, great. Thank you, Ms. Paul, for the invitation. I'm excited to be hosting with my good friend, Dr. Muck. So we're going to get started with the pelvic venous insufficiency. Next, thank you. So just a brief introduction. 40% of chronic pelvic pain is secondary to pelvic venous insufficiency, or what also some other refer to it as pelvic congestion syndrome, which is a pretty significant percentage. Next, please, Misty. So these are some of the symptoms: pelvic pain, dysmenorrhea, which is pain during intercourse, or it could be sometimes postcoital pain, and pelvic fullness and bloating. Actually, I saw a patient today standing for an hour and a half. She gets pelvic fullness and bloating. So these are some of the symptoms that we see with pelvic congestion syndrome. Dysmenorrhea, and then lower extremity edema. Next. So pelvic venous insufficiency could be due to ovarian reflux or internal vein reflux with or without an obstructive cause. And that's very important to remember. And if you see the diagram on the top right, you can see the red arrows showing the venous reflux. So as an example of an obstructive problem of the ovarian vein is what we know as the nutcracker syndrome, where the left renal vein is compressed. Am I still on?
We can hear you.
Yeah, I don't know. Sorry, I don't know why the picture is coming and going. So I'm just gonna leave some abbreviations, the CPP for chronic pelvic pain, PVI, which is pelvic venous insufficiency, and PCS, pelvic congestion syndrome, and then OVE for ovarian vein embolization, or an R for reflux, and iliac vein stenting. Also, I wanna bring to your attention in this picture something that the authors refer to as the pelvic reservoir. which you can see some of the varicosities in the bottom and the cross-filling from the internal iliac veins to both sides. So that's something we're probably going to be talking about also tonight. And finally, I think this is my last slide. I want to embarrass my, oh, sorry, one more. So, this is a dear topic to my heart. I personally have over 20 patients with, mainly I have nutcracker syndrome patients. I personally have found in my personal series that 90% of my patients have radiographic evidence of May-Thurner syndrome or compression of the left iliac vein. And I have changed my practice when indicated from doing left renal vein transposition to ovarian vein transposition. Sorry, Dr. Kovisky. But again, who knows, after today's or tonight's discussion, I might even add something else to change my practice. Next, please. Like I said, I want to embarrass my second year fellow, Dr. Zone. She just recently passed the RPVI, so she should proudly add RPVI, and I look forward to tonight's discussion. Thank you.
Thanks, Dr. Bachara. Can you guys hear me okay?
We can.
Okay, perfect. All right, so I'm actually really glad Dr. Bachara gave that introduction because that saves me a few talking points here. So I'm going to be discussing the article Pelvic Venous Insufficiency Secondary to Iliac Vein Stenosis and Ovarian Vein Reflux, treated with iliac vein stenting alone. Again, I'm Kayla Zorin, I'm the second year fellow at Loyola. The authors are listed here. This was recently published in the Journal of Vascular Surgery, Venous and Lymphatic Disorders. And the authors come out of the Center for Vascular Medicine and the Center for Vein Restoration, both in towns in Maryland. The study was funded by the Locke and Paul Vein Foundation, which provided an educational grant for the personnel who were working on the study, but the authors had no conflict of interest. Additionally, it was presented at the 34th annual meeting of American Vein and Lymphatic Society in Washington, DC last year. So pelvic congestion syndrome was first described in 1949. And since then, the leading hypothesis is that ovarian vein reflux with pelvic venous hypertension is the cause of the symptoms of pelvic congestion syndrome. There's a group, Rosenblitz, that looked at CT scans of female renal donors. And they noted that there was 47% of these patients that had ovarian vein incompetence that were asymptomatic, that kind of led away from this initial hypothesis. Additionally, the incidence of ovarian vein reflux requiring embolization is pretty low, 7 to 14%. Interestingly, the incidence of combined ovarian reflux with iliac vein stenosis is 33 to 60%. And there's the biggest study on patients with chronic pelvic pain had 1,280 patients. And what they noted is that 40% of these patients had combined ovarian vein reflux and iliac vein stenosis. And over half, 53% of these patients had isolated iliac vein stenosis. So this group actually had an article that was published in 2017 that was looking at patients, 227 women who had pelvic venous insufficiency. And what they found in their review is that 80% of these women had an iliac vein stenosis that was greater than 50% diagnosed on IVUS. Of these 227 women, they had various different treatment modalities. 39 of them had ovarian vein embolization alone. 94 of them had ovarian vein embolization with staged iliac vein stenting. 33 had simultaneous embolization with iliac vein stenting. 50 had iliac vein stenting alone. 8 had ovarian vein embolization with iliac vein venoplasty, and 3 had venoplasty alone. And what they found in the group that underwent ovarian vein embolization with staged iliac vein stenting is that only 9 of the 94 had a decrease in their pain score, the visual analog scale score, after the ovarian vein embolization. And after the stenting occurred, there was a significant decrease in the visual analog score. I think Dr. Bachara had a better picture of venous collaterals, just showing kind of the thought behind the ovarian vein reflux. So the authors, after their study, they were curious to see if iliac vein stenting alone would be a treatment modality that would reduce the incidence of symptoms from pelvic venous congestion syndrome. So they did a retrospective review from a single center from May 2016 to October of 2019. And they looked at women who underwent iliac vein stenting alone in patients who had ovarian vein reflux and iliac vein stenosis. And their hypothesis is that the iliac vein stenosis was the culprit that led to ovarian vein reflux and collateral circulation, and that the iliac vein stenosis was the culprit for the venous congestion symptoms, and just stenting alone would be enough to reduce symptoms. Over the course of the time frame, there were 510 total patients who had intervention for pelvic venous insufficiency. 164 had ovarian vein embolization followed by iliac vein stenting. The majority, 189, had simultaneous embolization and stenting, and 75 had embolization alone. There were only 82 patients of these 510 who had only iliac vein stenting. And of these patients, they selected for those who had both preoperative and postoperative VAS scores and documented stent patency to include in their cohort, which led them with 38 patients. I included the demographics here on the right side of the screen. You can see they had typical comorbidities. A few also had gynecologic findings. For these patients, the workup included a gynecologic evaluation for non-venous causes of chronic pelvic pain. All patients had a trans-abdominal ultrasound. They underwent diagnostic venography with intravascular ultrasound. And the venography included views of the bilateral iliac veins, IVC, left renal vein, left ovarian veins, and then any pelvic veins. Dr. Bachara showed us the example of the pelvic reservoir, which the authors looked at during the study. They defined the pelvic reservoir as the presence of cross-pelvic collaterals and at least 3 pelvic segments that communicated with the internal iliac vein or ovarian veins, either unilateral or bilateral. And for follow-up, these patients underwent duplex ultrasound at 1 week postoperatively, and then 3, 6, 12, 18, and 24 months postoperatively. Their endpoints that they looked for were symptom resolution using the visual analog scale. They looked at patients specifically who had pelvic reservoirs, and then also selected for patients who had dysmenorrhea, and they also looked for stent patency. So in this table, there's a few things I want to point out. So first of all, looking here at the VAS score for pelvic pain, they looked at patients who had dysmenorrhea and dyspareunia separately, and they found that both patients, both groups of patients had a statistically significant decrease in their postoperative VAS score compared to preoperatively. You can see that it was a little bit higher for patients preoperatively with dysmenorrhea at 6.86, and it dropped to 1.7 postoperatively. And patients who had dyspareunia started at 4.3 preoperatively, went down to 0.41 postoperatively. More importantly was the response rate. So 28 out of 38 patients, 76% had a complete response, which means VAS score of 0, so no pelvic pain. When you excluded for those who complained of dysmenorrhea, this actually went up to 92%. 35 out of 38 patients had a complete resolution of their pain, or a VAS score of 0. The average stenosis was about 74% in the iliac vein. Looking at the stents that were used, the average diameter was about 18 millimeters, and the average length was about 95 millimeters. And they used the Venovo and the wall stents. Most stents were placed in the left common iliac vein. That was the common place for the iliac vein stenosis. But they did have 3 in the right common iliac vein, and then 3 that were bilateral. And then additionally, looking at the pelvic reservoir. So of these 38 patients, 17, or just under 50%, had a pelvic reservoir present. 10 of these 17 patients had a complete response postoperatively. So 59% still had a complete response to iliac vein stenting. 1 had no response, and then 6 or 35% had a partial response. One other thing I think I forgot to highlight on here is that I'm going to discuss a little bit later is the average ovarian vein diameter. For this study in particular is 6.6. Additionally, there was 7 out of 38 patients who had to undergo reintervention. If you look at patient 1, 3, 4, and 7, they all had left-sided common iliac stents placed and then came back and had a stent placed in the right common iliac vein for some kind of symptom recurrence, whether it was leg symptoms or pelvic symptoms. There's one patient who had common iliac stent placed on the left and then had it extended into the external iliac vein for symptom recurrence. There's one who had bilateral stents placed and then had an extension into the right common iliac vein. And then interestingly, there was one patient who actually had a left external iliac vein stent placed initially, underwent ovarian vein embolization because they did not have a response, and then they were found to have a labrum tear that was responsible for their symptoms. So there have been multiple previous reports that have shown that ovarian vein embolization alone doesn't actually cause a significant reduction in symptoms for these patients with pelvic venous insufficiency. And oftentimes these patients have a VAS score higher than 3 after intervention. The questions that the authors brought up as to why this is, did these patients have inadequate treatment of the pelvic reservoir? Is it because they didn't do bilateral ovarian vein embolization? Is there a presence of an unrecognized iliac vein stenosis that wasn't treated? One thing that they found is that 58% of these patients who had a pelvic reservoir were asymptomatic after having their iliac vein stented alone, which suggests, that this may not be, the pelvic reservoir may not actually be indicative of whether or not patients are going to be symptomatic afterwards. Ultimately, there needs to be a larger study to determine exactly who may require ovarian vein embolization. There's a question of whether there's a quantitative measure that we can look at when it comes to the pelvic reservoir that could potentially guide treatment. Could the size of the ovarian vein affect, whether or not we elect to embolize it or not? There was a recent study that was published that also they performed an iliac vein stenting first, and it was followed by ovarian vein embolization if the patient had persistent symptoms. What they found is that the average diameter of patients who required ovarian vein embolization was 10.4 millimeters. I pointed out from this study the average ovarian vein diameter was 6.6 millimeters. One thing that was different between this study and the study that I'm discussing is that they didn't use IVUS. So there's a question as to whether or not there's iliac vein stenosis that was undiagnosed. Currently, the authors from this study recommend that iliac vein stenting is performed initially in patients who have combined iliac vein stenosis and ovarian vein reflux, and to consider ovarian vein embolization at 6 months if persistent symptoms, if they have persistent symptoms or an incomplete response. Limitations that I've hinted to are that this is a relatively small sample size. They also had relatively short-term follow-up. The average follow-up was 6 months, and it was a retrospective review. There was 510 patients who underwent intervention for pelvic venous insufficiency. So it's unclear why the surgeons elected to just perform iliac vein stenting on these patients versus the other patients that presented during the time frame. So in conclusion, women with pelvic venous insufficiency should be evaluated for iliac vein outflow lesion. And if the venous insufficiency is secondary to iliac vein stenosis and ovarian vein reflux, people should consider stenting the iliac vein alone for symptom relief and reserve ovarian vein embolization for those with continued symptoms at 6 months. Thank you.
Thank you, Dr. Thorne. That was a great summary of this paper, and I found it really interesting. There are some questions starting to come through in the chat, but I thought there were a couple of points to this article that I wonder if you can help shed some light on a little bit. I really like the way you focused on the pelvic reservoir, and I think in the article there's one line in the in the conclusion that throws me a little bit, which is that the women with partial response had a pelvic reservoir present. And it was a little hard for me to gather that from the meat of the results in the article, but I'm curious if you have any insight into this, or if you can at least think about whether imaging results of the presence of a pelvic reservoir after stenting made a difference in those patients who had residual symptoms. And what I mean by that is occasionally after you stent the iliac vein, you'll relieve the pressure and alleviate that cross-pelvic filling and the filling of the pelvic reservoir. So I wish the authors might have included, and maybe you have some insight onto whether resolution of that pelvic reservoir filling was indicative of a good response versus an incomplete response in these patients. And I also really appreciated that you brought up the dysmenorrhea as a symptom. And I wonder whether that, the results that they gave were really nice, including or excluding the dysmenorrhea only patients. I wonder if that should be part of what we include in our treatment algorithm as far as indications for this procedure, since there's so many other potential causes besides iliac vein compression. We'll start with those.
I will say I was looking at the table too when you were talking about the pelvic reservoir and the response. It definitely wasn't clear, whether or not these patients had postoperative imaging that looked for resolution of the reservoir. So it'd be very interesting to see that.
Yeah, I'll just add, that's a great point from Dr. Politano. I would add to that is that, which brings one comment I would like to also add is that, the fact that patient had hysterectomy, because we used to think hysterectomies, it could resolve the symptoms. So like I said, the patient actually saw today in clinic had hysterectomy, but she's still having the heaviness in the pelvis and the bloating and the fullness. So it could help with the dysmenorrhea, but not necessarily with the other symptoms. So we need to keep that in mind. To be honest with you, about this pelvic reservoir, I mean, obviously we have some experts in the venous disease who can comment. I've actually had to treat few. They're not easy to treat, to be honest with you. They're very robust filling. So the answer, I personally, I don't know. The answer to you is I don't know what to do with the pelvic reservoir. Also, I personally would like to know what's their algorithm. We never really talk about the right ovarian vein. Is that next in line after the pelvic reservoir? So I think there's a lot of things that we don't really know yet. But to be honest with you, I think starting with the iliac vein, to me, that was an eye-opener. It's a good start. And then eventually move on to other, treatment algorithm down the line.
Yeah, I appreciate that. I think this article could have helped add to that knowledge base for all of us if we had included a little more information on that. I've definitely seen that reservoir completely stop filling after stenting, but if it persists, that becomes a different question, I think. Dr. Higurani asked the question, the average age is 47 years old with, it was a 12-year age range. Is it okay to stent young patients when we really do not have 20 to 30-year follow-up data for iliac vein stenting?
Well, I'll take it too, Kayla. So, I mean, it's a good point. All I can say is that I hope with the new venous stent coming on the market, we'll have better patency. So that's all I can say. But on the other hand, like I said in the chat, I mean, it's a various vein transposition or renal vein transposition. I mean, they're beautiful operations, very elegant, but they're big surgeries too for a 20-year-old.
Well, and Dr. Lawrence brought up a question, is ovarian vein transposition an option after iliac vein stenting if symptoms persist? And has anyone here done that with a left iliac vein stented?
A good question. I haven't, to be honest with you. I'm not sure if anyone else, but it is a concern. Now, I personally, when I do a various vein transposition, I take it to the cava if I can, because of the findings that most of the patients do have some sort of iliac vein compression. So I personally, if I can, I take it to the IVC.
In addition to or before iliac vein stenting?
No, so this, I've never, to be honest with you, I've never done it. Like I said, in my personal series, I've had a lot of patients with, I noticed that 90% had the compression of the left iliac vein, but I've never, I didn't touch it in any of the patients. So, but like I said, I mean, this new article is I'm gonna have to incorporate some of this treatment algorithm into my practice. But yeah, no, I haven't done it yet.
Another question from the chat box, Dr. Babak Abai, based on this study, would you recommend iliac vein stenting as the first line treatment? And what is the physiology that is responsible for this?
So good question. So one thing I would like to also throw out there is that, you know, the iliac vein, we don't have any valves in the iliac vein. The Ovarian vein, we do have valves. So we don't have in the common, and usually we don't have in the external. So I think part of the compression is causing some of that reflex. Now, interesting, like Kayla mentioned, is that the ovarian vein was only 6 millimeter. I mean, most of the patients I see, it's honestly 10, 11, 12 millimeter, huge ovarian veins. But basically it's because of the pressure, it's causing basically back pressure into the ovarian vein, into the internal iliac vein. And then, like you mentioned, the pelvic reservoir. So it's basically a compression leading to reflux. That's the physiology that I could explain it the simplest way. But again, data, we're all here. I mean, we're discussing this paper because the data, I mean, that resolution, 76%, that's a really fantastic response. And 93. So like I said, I'm going to incorporate this treatment algorithm in my patients. But again, I don't know where it will fit, but I'm definitely interested in trying it.
So I feel like,
Ronnie, is it okay if I
yeah, I
jump
was gonna
in
say,
real
I
quick?
feel like Bill is not sold on this right now.
Yeah.
So
Yeah, I was going to say, so I think it's really critical to understand how bad the iliac vein is. And I worry about the whole 50, 60% narrowing, because I've had a lot of patients for leg symptoms where we did it, it's 60% and they just don't get much better. So I think there's a big difference between a 90% narrowing of the iliac and a 60%. So look at that versus, you know, if you got a big ovarian, like you said, you know, those 10, 11 millimeter, that may be a better place to go than a moderately narrowed iliac, which a lot of us have sitting here.
So Bill, I have a question for you. You said, you know, for leg swelling, you do this. And I know that's not the topic of this paper, but why don't you think they get better? If they have leg swelling and we're going in and they have compression, I mean, I find venous patients really tricky. I think there's so little for us to understand. I mean, even doing the venogram for some of these patients is challenging to interpret it and figure it all out. And I'm doing pressures. Why don't they get better? There's a stenosis. I fixed it.
Yeah, we don't understand it well enough. And I can tell you just this from data we looked at in the Venity Boston Sci trial. So 200 patients, we tried to correlate the amount of narrowing by IVUS or venogram to symptom improvement by the BCSS. And it was very hard to correlate any specific measurement. So it's more than just one measurement. It's length of disease and a lot of things. So in that middle range, about half of them get better and half of them don't by their symptom scores. Now, if you got a 90% narrowing or a complete occlusion, they almost all have symptom improvement.
So when Bill, and I'll ask Bill and Carlos the same kind of question, maybe you can address it. How do you determine if you're going to transpose an ovarian vein or if you're going to embolize it? Like, do you have specific criteria for either one?
I'll let you take this one.
Okay. I can't agree. With you more. I mean, they're tricky, and I tell my venous patients, I learn a lot from them. Honestly, that's what I tell them. And but honestly, so a few years ago, 2013, I think at SCVS, we published. We all talk about now again we're shifting to the nutcracker syndrome, but we talk about the angle between the SMA and the aorta. So what I noticed is that I did two renal vein transposition in 1 week. One had perfect result and the other one not so perfect result. And I was like, it's the same operation, same technique, why? So I went back and looked. The angle does not change much sometimes in patients, even if you bring it down an inch, it doesn't change. The angle is so tight. Some go like this. So we looked at it and we showed the ones that did not have a good response because the angle is, even if you move it down. And if you look at Dr. Kavitsky's paper, I mean, he added some adjunctive procedures. He patches the renal vein, he added now a stent. So obviously there are other things that's happening that that's requiring to treat the renal vein. So I personally, if the ovarian vein is large and the patient have kind of both symptoms, some combination of nutcracker with some pelvic congestion syndrome, I transpose ovarian vein.
Dr. Klavitsky, you are being very gracious. Do you want to make a comment?
Well, I think I love the discussion. It obviously tells us that this is a controversial topic. As I mentioned, the limitations of this paper are significant, as it was mentioned before. I have a hard time to recommend iliac vein stenting first if the patient has a pelvic venous congestion due to an incompetent ovarian vein. So if there is a large ovarian vein and the ovarian vein is the cause, I certainly would treat that first. And I agree with Dr. Hingorani that, I am just concerned that this paper will start putting in even more iliac vein stent into young women who really don't need it. So I think following this paper, we should start some comparative studies and then we can make a decision. As far as the transposition, I think the transposition is not going to, that certainly shouldn't be a first procedure for pelvic symptoms. Transposition is an operation for not symptomatic nutcracker syndrome. You either do a transposition or you do you either do a transposition of the renal vein or a transposition of the ovarian vein to improve the renal circulation, and with that you help the pelvic circulation as well. So I think it's a great paper that opened Pandora's box.
Well, on that, I think we will move to the next paper and Dr. Muck can help us open another box.
Thank you, Misty. Thank you, Paul. If this was an NFL game, I want to note that Carlos has monopolized the time of possession here. So to that end, let's go ahead and get started here. Thank you again. This is super cool and an honor for us. A couple facts. I only have a few slides here, but as we know, chronic venous insufficiency affects anywhere from 10 to 35% of adults. Primary is considered more common than secondary. Varicose veins are the most common presentation in a Western population, but 2 to 5% of folks can have skin changes and ulcerations, and chronic venous ulcers or venous leg ulcers, VLU, affect about 1.5% of the Western population. And as you can see here, it is a heck of a cost to society. This also is near and dear to our heart. Recently, our 0 and 5 fifth year Brent Robertson, seen here with past President Kelly Brown, was lucky enough, not lucky enough, he did a heck of a job and won the Pfeiffer Award for the best venous paper at our Midwest Vascular meeting last week, where he analyzed the venous stent patency and determined that it's independent of total stented length for both nivels and post-thrombotic lesions. So Peter, be on the lookout for hopefully a paper you'll be happy with that's coming out of the Midwest from our institution. No discussion on iliac venous stenting can really go on without recognition of the Olympian here of venous interventions and Dr. Raju. We all know what he did in the 2000s and multiple publications really showing the benefits and the clinical impact of venous stents on the management of chronic venous insufficiency and really highlighting the importance of IVUS. He also taught us the terminology such as NIVL, thrombotic iliofemoral venous obstruction, and post-thrombotic iliofemoral obstructions. Following that, societal guidelines then followed the AVF and partnered with the SVS and came out with this consensus clinical practice guideline document. And one of those was guideline 6.14, which identified folks with venous leg ulcers or C4B or healed C5 should undergo venous angioplasty and stenting. And a lot of these guidelines were built upon the shoulders of Dr. Raju and Dr. Neglin. Then our president-elect from the American Venous Forum, who we're lucky to have with us tonight, Bill Marston, did further research focusing on folks with C5 and C6 disease and noted over 35% of those folks had underlying significant iliofemoral stenoses, really highlighting the fact that we need to be aggressive with these patients and really search for the cause of their disabling chronic venous insufficiency. And ultimately, all this work led to the FDA approved stents. The wall stent was subsequently FDA approved, but first was the one below it with the flared ends, the Venovo, which will be back by the end of this calendar year. Top right's the Abre. That's a nice pinwheel spot on deployment. And then tonight, I'm going to turn over the reins here to our fellow, Dr. Adam Reichert, to discuss the one to the bottom right here, which is the Zilver Veno, which we were fortunate enough to be a part of their Vivo trial. So to that end, Adam, please go ahead and share your slides and let's discuss this paper.
Will do. Can you guys hear me?
We can.
Okay, Dr. Muck, thanks for the introduction to venous stenting. I was trying to share my video, but honestly, the moderator is probably doing you a favor since you can't see me there. So let me see here. All right, I'm going to present a study out of China, and the title of this study was Clinical Outcomes of Venous Self-Expanding Stent Placement in the Treatment of Iliofemoral Venous Outflow Obstruction. This was a single institution retrospective study that reviewed the data of 49 patients between September 2017 and March 2019. The goal of the study was actually to determine the one-year patency rates, as well as the clinical effectiveness and the safety when Zilver venous stents were used for the treatment of iliofemoral venous outflow obstructions. And like I said, the study itself included a total of 49 patients, all with iliofemoral venous outflow obstruction. These obstructions were secondary to either acute DVT, nivels, or non-thrombotic iliac venous lesions, or post-thrombotic syndrome. All these patients were stented using Zilver venous stents, which are supplied by Cook Medical, and these are flexible, self-expanding bare metal venous stents. And at the time of this study, this was actually the only venous stent approved for use in China. The clinical data was retrieved from the patient's medical records, and this included patient demographics, their clinical presentation, whether or not they had a hypercoagulable disorder, Volta scores, venous clinical severity scores, as well as the characteristics of their DVT if they were indeed diagnosed with a DVT. To quickly go over the procedure, the femoral or popliteal vein of the affected extremity was accessed using ultrasound guidance, and then a 7, 8, or 9 French sheath was placed. A catheter with a guide wire was then used to cross the venous blockage, and they used phenography to assess the location and severity of the venous blockage. And they also used phenography to assess for any inflow problems. And then the last thing they did with that was just confirm placement of the catheter into the true limit of the IVC. After that, all patients underwent balloon angioplasty prior to stent placement. If the patients were diagnosed with acute DVT, they underwent either pharmacomechanical thrombolysis, catheter-directed thrombolysis, or a combination of the two, and then underwent balloon angioplasty and stent deployment. Also, patients with DVTs had an IVC filter placed pre-procedure via the contralateral femoral vein, and those were all retrieved at 30 days. So all patients got a Zilver venous stent. There were a few patients that required more than one stent. When a second stent was needed, a wall stent was placed. In those situations where more than one stent was placed, there was 3 meters of overlap between the stents, and then phenography was performed after stent placement to visualize the final position of all the stents. All patients were instructed to wear class 2 compression stockings post-procedure and return to normal activity within 24 hours. They were all started on a combination of therapeutic anticoagulation and antiplatelet therapy via aspirin for at least 6 months. The majority of patients in the hospital were started on low molecular weight heparin and then transitioned to rivaroxaban at discharge. If patients had a concurrent diagnosis of cancer, they were kept on low molecular weight heparin at discharge. And if patients had a diagnosis of a hypercoagulable disorder, it's possible that the duration was longer than 6 months and potentially even lifelong. Clinical follow-up exams were performed at 1, 3, 6, and 12 months, and then annually. The stent patency was evaluated using color Doppler ultrasound, and symptom and clinical improvement was assessed using Volta scores for patients with post-thrombotic syndrome, and then venous clinical severity scores for patients with both post-thrombotic syndrome and non-thrombotic iliac venous lesions. For the patients with acute DVTs, they defined clinical improvement as either a decrease in pain or swelling within the first 24 hours following their intervention. In this study, technical success was successful recanalization following the stenting procedure without any major procedural complications, and they defined those complications as access site bleeding requiring a transfusion or reintervention within 30 days. As far as primary patency, that was considered a less than 50% stenosis on color Doppler ultrasound that did not require intervention. Assisted primary patency was over a 50% stenosis requiring some sort of secondary endovascular intervention. And then secondary patency was an occlusion of a venous stent requiring a repeat intervention. So on to the important part of this paper, the results. You can see there on the left, there's a table that had just some baseline demographics as well as lesion characteristics. Of the 49 patients in this study, 19 had a diagnosis of acute DVT, 23 had post-thrombotic syndrome, and 7 of the patients had non-thrombotic iliac venous lesions. In the 49 patients, a total of 58 stents were placed. They all got Zilver venous stents, so 49 of those were placed, 9 wall stents were placed. So 1 patient got 1 Zilver venous stent and 2 wall stents, and then 7 patients got a Zilver venous stent with a wall stent. Recanalization was successful in all 49 patients, which is an excellent result. And for patients with acute DVT, they saw clinical improvement in 84% of the patients with acute DVTs, and that was 16 out of 19. No severe complications were noted. The most common complaint post-procedure was actually slight back pain. They noticed a trend towards people having back pain when larger diameter stents were used, but they weren't able to show that using statistics. As far as the patency results, during follow-up, out of the 49 patients, only 3, so 6% of patients developed in-stent thrombosis or obstruction requiring a reintervention. Out of the 3 patients that developed in-stent thrombosis or obstruction, 2 of them were able to be recanalized. 1 wasn't. The one that wasn't able to be recanalized was one of the patients with post-thrombotic syndrome. And the paper did note, even though they weren't able to recanalize that patient, when that patient followed up at 6 months, they noted significant clinical improvement. You can see the primary and secondary patency rates at 12 months there for the 3 different types of lesions. I think the important part is listed next, and that's the overall primary assisted, and secondary patency rates, which were 93.8, 95.9, and 97.9%. These 2 graphs, so the graph on the left are the Volta scores. So this is for patients with post-thrombotic syndrome, and these are pre and post-procedure Volta scores. And you can see the pre-procedure Volta score was 19, and that decreased all the way down to 4 after the procedure, and that was statistically significant with a p-value of less than 0.001. And then on the right, that graph is the venous clinical severity scores pre and post-procedure. That was patients with post-thrombotic syndrome and non-thrombotic iliac venous lesions, and that also showed a significant decrease from baseline with a pre-procedure score of 11 down to 3 post-procedure. So after these procedures, these patients did see some significant clinical improvement. As far as discussion, this was a well-organized study. I think they did a good job of showing that these stents are effective, that they do cause clinical significant improvement, and that they are safe to use. Like all studies, there were limitations to this study. It was a retrospective study. It was a relatively small sample size. There were 49 patients. It's a non-randomized design. And even though it was 12-month follow-up, that's relatively short follow-up. I know, a lot of patients getting these stents are younger, and they may have these stents for 10, 20, 30, maybe even 40 years. And we obviously don't know the patency rates when it gets out that far. I think another limitation that they didn't really allude to was the lack of intravascular ultrasound. This was not available at their institution during the time of the study. There is a really nice study from Dr. Marston and colleagues titled Venography versus Intravascular Ultrasound for Diagnosing and Treating Iliofemoral Vein Obstruction. And in this study, they compared the diagnostic efficacy of multiplanar venography compared to intravascular ultrasound. And the conclusion of that study was just that intravascular ultrasound is more sensitive at identifying treatable iliofemoral stenoses. And interestingly, they actually, after performing intravascular ultrasound, 57 of the 100 patients had revised treatment plans, which is pretty significant. And ultimately, the conclusion of this study was that Zilver venous stents do have excellent 1-year patency and secondary patency rates when used for the treatment of iliofemoral venous outflow obstruction secondary to either acute DVT, nivels, or post-thrombotic syndrome. But like most studies, additional randomized control trials or large-scale studies are needed to just provide us with more evidence to support the use of these stents when treating iliofemoral venous outflow obstructions.
Well, that's really an excellent summary, Adam. And I really can mostly just echo what you've said about this paper. But since Dr. Glowicki's here, I have to review it as I would as a JVS VL reviewer. So I always think first about the methodology and the strengths and weaknesses. And as you said, despite this being a relatively small retrospective study, the strengths are that they really did a nice job of doing the VCSS and the Villalta score routinely on these patients. And, we do the VCSS pretty routinely in our clinic. It's pretty quick to do, but the Villalta is not that easy, takes time. And so doing that routinely to be able to find it on a retrospective review, I think is really impressive. And their findings were not subtle. I mean, going from a VCSS of 11 pre-procedure to 3 on the average post, that's a major improvement in symptoms. So I think they've demonstrated that in their hands in this small study, stenting with the Zilver really was impressive. However, that being said, I think the biggest weakness of this is that they combined acute cases with nival lesions and post-thrombotics. It's sort of like doing a AAA study, and you're going to include FEVAR patients with infrarenal endos and some iliac lesions to do outcomes. And so you wonder if one group sort of drove the outcomes more than the others, and can you apply the findings to all 3 of these etiologies, which are really disparate groups. We're really trying to kind of bring data to specific types of venous patients because they behave differently. That being said, I think their conclusions sort of are additive to other retrospective studies that show that this procedure does have benefit for patients, but now it's really about defining which patients should undergo the procedure. And I think everybody's aware of the C-TRACK study that is currently going on, that is a prospective randomized trial comparing standard care with compression to venous stenting for this patient population. So please make sure you send all your patients to a C-TRACK site. So I think that's really my summary. I think you did a great job on it. I was going to ask Patrick just, really quickly, they just studied the Zilver, but I don't know that any of these results you would say are, unique to the Zilver. Would you, Pat? And what do you guys use?
Yeah, no, we use a mixture of Abre and we were in the Vivo trial, so we use Zilver Vena as well. like you said, though, if you talk like an engineer about crush resistance, flexibility, radial strength, and all these stents have all been tested on a benchtop model. They're all pretty much the same as I think what you're alluding to. So I would expect these results pretty much with Venovo when it comes back. It's definitely coming back, but we've had good results with Venovo. I know others have had good results with Abre. So I don't think the findings are unique to this.
It's pretty remarkable how similar the clinical trial data was from each of the stent, nitinol stent trials.
Yeah.
Here's a great question from Misty about anticoagulation. And Adam, I don't think I saw anything about their anticoagulation protocol in the paper. Did they mention that?
They did mention that all of the patients were on a dual treatment with therapeutic anticoagulation and antiplatelet therapy with aspirin. They didn't say specifically what it was. They did allude to the majority of patients being on low molecular weight heparin and then being transitioned to rivaroxaban. It was different for patients with a concurrent diagnosis of cancer and patients with hypercoagulable disorders.
Pat, what's your guys' protocol?
Yeah, so, I thought it was interesting in that paper that all of them, including nibbles, were fully anticoagulated, which is not our practice. And as you know, more work needs to be done. But I think we follow what I'm guessing you do, and that's for post-thrombotics, we anticoagulate for 6 months, perhaps cut the dose in half based on duplex findings at 6 months. But nibbles, we do antiplatelet therapy, monotherapy with Plavix, not even dual therapy.
Yeah, we do the same. The same group that did the first paper published on NIVL patients, so not post-thrombotics, not acutes, and suggested that there's no need for anticoagulation, but again, not a randomized study. And the other caveat is we just recently published in JVS VL that if you look at patients that have total occlusions of the iliac, they're a different subset because you've got to recanalize that whole iliac channel, and they are more prothrombotic than those that you don't have to do that. And we had a high rate of rethrombosis in patients who were anticoagulated with DOACs. So we use low molecular weight heparin for those patients, just those that have total occlusion with recanalizations, and we do low molecular weight for 3 or 4 weeks before then you can switch. I think it much more anti-inflammatory, and in our data, there were significantly fewer reocclusions early.
Phil, would you leave those patients on long-term though? Like,
We
are
go
you gonna leave that patient on forever, maybe?
No, so I think it's key until the stent covers over. So the metal's not exposed to the blood. And then you go back to what's their overall risk. So at 6 months, usually, then we reassess, do they, how's the flow through it? Does it look good? Are you getting any restenosis? If it looks good, there's no restenosis, then it just, I think you could switch to antiplatelet if there's no high risk of repeat thrombosis. But a lot of those patients are they've had multiple episodes of DVT and they're just on long-term anticoag.
I also want to see if you guys could both address the question by Dr. Politano, because I think this is something also, the oversizing. In this paper, they talked about if it was a little oversized, the patients had pain. There's stuff from other arterial beds saying that if you and when we use a little bit oversized, maybe the cells are smaller so you don't get ingrowth. How much are you oversizing? What are your thoughts on that? I think that's a really important question too.
Yeah, for us, everything's IVUS based. You take a diameter of the area proximal, not the area that's kind of pre-dilated. And then you're going to take the diameter, in 2 planes there, add them together, divide by 2 and upsize 10%. With that being said, it seems like we almost always put a 14 in if it's a larger in the common iliac and an external iliac, and a 12 and a common femoral. Unless perhaps it's a larger gentleman, then sometimes it's a 16 into the common iliac vein. But I think I agree with Imani's point. Oversizing that much, you're gonna you're gonna cause pain. You're gonna be getting calls to your office. I thought it was interesting in the paper that they admitted some of them, if not most of them, for 3 to 7 days. I'd love to see that practice here in America and how Humana and Blue Cross and Blue Shield would deal with that. But I agree, 20% is too high. Ours is 10%.
I think this is an area too where you have to separate into the post-thrombotic that have a chronically narrowed, the whole channel is narrow, versus the point compression usually at the common. The post-thrombotics usually are struggling to get that open to 16 millimeters, like Raju says you want to get it to. So we're usually using 14 or 16 proximally, but they're very long stents. Or a lot of times you're going all the way down to the common femoral, versus a nivel with that obstruction right at the confluence. These are tricky. They're tricky because, if you look at the ones that migrate, it's very rare that they migrate if they're larger than 14. And so you've got to really measure that carefully with IVUS and be sure that you're not undersizing that stent. Remember, they're supine, and you've got to make sure you match it to the more distal iliac, and also avoid using short stents. We've gone to almost always using 100 millimeter stents, even for focal lesions, because migration is obviously it's going to be a really bad thing, so you want to avoid that.
That's why our
But
paper in the Midwest, that's why we looked at it because if you ask Medtronic, their most common stents of 14-120, and we want to show that, a 120 versus 100 or less we surmised that it had similar patency, and that was our paper at the Midwest, and it confirmed that.
So another great question from Amani about, are we seeing less migration? I don't think anybody knows the incidence of migration because many times they're not reported. And we do know that pretty much every stent that's been used enough has migrated. So I don't think it's so much related to the stent characteristics as it is to the stentors. And again, just being very careful that you're sizing these well and not using short stents for focal lesions.
Bill, I got another question for you. Going forward, I guarantee if the authors from China were on and we asked them the names of 49 patients, they couldn't rattle them off. But if you said, what's the names of the 3 people that occluded, they could rattle them off. We all have these,
Yeah.
Here in Cincinnati, there's a Jessica running around and an Ashley that as soon as we see them in the ER or on our schedules, we all just take deep breaths.
Right.
So we're going to have problem folks, not every stent's going to stay patent. So what do you think in the future, if anything's going to help this 2 to 3% of folks who, no matter what you do, you can't keep the iliac vein stent open?
Yeah, I think the first thing is, and we'll talk about the future, but right now we don't have a solution for it. So you want to prepare patients before you do this. So somebody has really good inflow from the femorals below, and they've got a relatively straightforward lesion. The risk that they're going to have restenosis is probably no more than 1%. But the post-thrombotics, it is more in the 5 to 10% range. And you just have to talk to them and let them know, if we do this procedure, there's a small chance that this could happen and we won't have a solution, and eventually the stent will go down. And yeah, everybody talks about doing a Palma crossover, but Dr. Glavitsky, have they done these at the Mayo recently? I mean,
well, I don't know if they have done it very recently, but it's time to learn the Palma procedure, guys.
Yeah.
All right, that's a good operation if you have a good vein and you have a unilateral occlusion.
Well, the problem is nobody has a good vein anymore, because by the time they get there, somebody already ablated it. And the last 2 patients I wanted to do it on, they'd had the saphenous ablated. So that's my problem.
And it was probably a great size to do it, right?
Yeah, exactly. So then the other question, Pat, is, what do we have for this in the future? And the biggest thing is learning about what the material is that is occluding the lumen. Is it, like in the arterial system, and most of what I've heard from the folks at Michigan who have been doing some stuff on this in Raju is that for most of them, it doesn't seem to be like intimal hyperplasia. It's more of a post-thrombotic thing that starts it. So, paclitaxel and those sorts of things may not be effective. Could we go in and carve it out, some type of venous, endarterectomy device? Maybe, but I don't see why it wouldn't come back. And a lot of it's related to the inflow. So it's improving the inflow that probably is the real answer.
Well, there's a lot of conversation that's been generated. It's been a great night. We're super grateful to Dr. Muck and Dr. Bachara for hosting this evening. Also very grateful to our moderators, Dr. Marston and Dr. Politano. A really great conversation. There's just not enough information about venous disease. We do want to encourage you to join us again on October 13th. We'll do this another time. Different topics, different hosts, but exceptionally good conversation. And we thank you all for a wonderful evening.
Thanks, everybody.
Thank you, everyone.
Thanks, everybody. Great job.
Take care, everyone. Bye-bye.
Right.